Hello, I'm Dr. Jeffrey DeSarbo, and welcome to the Eating Disorder News Network Special Report. The current methods of diagnosing and classifying mental health disorders, including eating disorders, rest with the Diagnostic and Statistical Manual's 4th edition, which is currently under a major revision and due out in 2013. Recently, preliminary draft revisions of the upcoming DSM-V were released to the public for review, and the committee is accepting comments and input until April 20th of 2010. This special report is to bring you up to date with some of the changes proposed with eating disorders and body dysmorphic disorder. Let's begin by looking at bulimia nervosa and the proposed changes for the new DSM-V with that disorder. Most criterion remains the same for bulimia nervosa, except that for criterion C there is a modification as well as no subtyping with the disorder. Similar to the DSM-IV, the criteria includes recurrent episodes of binge eating, characterized by both of the following. One is eating in a discrete period of time an amount of food larger than most people would eat under similar circumstances, and 2 is a sense of lack of control over eating during that episode. Criterion B is recurrent inappropriate compensatory behaviors in order to prevent weight gain. And the modification that is being recommended is that binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. This is a change from what currently is in the DSM-IV, which requires that the behaviors occur on an average at least twice a week for the last 3 months. A literature review found that the clinical characteristics of individuals reporting a lower frequency of once a week were similar to those meeting the current criterion, and that it has been recommended that this modification be placed in the new upcoming DSM-V. Criterion D is a self-evaluation unduly influenced by body shape and weight, again, is remaining the same, and criterion disturbance does not occur exclusively during episodes of anorexia nervosa. And again, what is different and being proposed for the new DSM-V is currently the DSM-V the DSM-IV requires that subtyping, purging, or non-purging be specified. However, literature reviews indicated that the non-purging subtype had received relatively little attention, and the available data suggests that individuals with this subtype are more closely resemble individuals with binge eating disorder. In addition, precisely how to define non-purging inappropriate behaviors is unclear. This also requires a possible rewording of criterion B for bulimia nervosa. Next, let's look at the proposed changes for anorexia nervosa. Criterion A, it has been recommended, have its rewording changed to read, restriction of food intake relative to caloric requirements leading to the maintenance of body weight less than a minimally normal weight for age and height. Weight loss leading to maintenance of body weight less than 85% of that expected, or failure to make expected weight gains during periods of growth, leading to a body weight less than 85% of that expected. This is a change from the current DSM-IV reading, which focuses on a refusal to maintain body weight. The word refusal in the DSM-IV was viewed as possibly pejorative and difficult to assess as it implies intention, and this recommendation has been made to help with clarification. It is recommended criterion B read as intense fear of gaining weight or becoming fat even though underweight, or persistent behaviors to avoid weight gain even though underweight. In the DSM-V, fear of weight gain is required. However, a significant minority of individuals with the syndrome explicitly have denied such fear. It is therefore recommended that the addition of a clause to focus on behavior would benefit in clarification. Criterion C basically would remain as it is currently in the DSM-IV, which focuses on disturbances in the way in which one's body is perceived. However, what would be new would be the elimination of criterion D, which is currently in the DSM-IV. Right now, in the DSM-IV, amenorrhea is required. However, individuals have been described who exhibit all other symptoms and signs of anorexia nervosa, but who report at least some menstrual activity. Additionally, the criterion cannot be applied to premenarchal females, to females taking oral contraceptives, to postmenopausal females, or to males. Currently, the DSM requires that subtyping, which is both restricting type as well as the binge eating purging type, be included with anorexia nervosa and be specified for current episodes of the disorder. It has been recommended that in the DSM-V there be a qualifier which includes a time frame of during the last 3 months for pattern behaviors. This again is for help with clarification. When looking at proposed changes for the category eating disorder not otherwise specified, the works group thinking is that there is a consensus that eating disorders NOS is used more frequently in clinical settings than is desirable. And recommended changes should reduce the need for this category, but the category remains a work in progress and is dependent on final revisions to other eating disorder categories, such as those including a recommendation that binge eating disorder be recognized as an independent disorder in the new DSM-V. Recommended changes in the criteria for anorexia nervosa, bulimia nervosa, and for eating and feeding disorders usually beginning in childhood should also reduce the need for eating disorder NOS. If these recommendations are accepted, the examples in eating disorder NOS will be changed accordingly, and new examples will be required. The work group is also considering whether it may be useful and appropriate to describe other eating problems, such as purging disorder, which is a recurrent purging in the absence of binge eating, and night eating syndrome, a condition more commonly reported in the literature these days. Furthermore, measures of severity would be required, and these conditions might be listed in the appendix of the DSM-V. Binge eating disorder is currently listed in Appendix B of the DSM-IV, criteria sets and axes for further study. The work group is proposing that the disorder be moved from the appendix to a freestanding diagnosis in the DSM-V. Criteria for binge eating disorder is proposed to be as follows. Criterion A defines what an episode of binge eating is and is similar to that which you would find under bulimia nervosa, in that a binge eating episode is characterized by both of the following and includes eating in a discrete period of time an amount of food larger than most people would eat, and a sense of lack of control over eating during the episode. Under Criterion B, a definition is required that states the binge eating episodes are associated with 3 or more of the following 5 criteria. 1. Eating much more rapidly than normal. 2. Eating until feeling uncomfortably full. 3. Eating large amounts of food when not feeling physically hungry. 4. Eating alone because of being embarrassed by how much one is eating. And 5. Feeling disgusted with oneself, depressed, or very guilty after overeating. Criterion C would include a marked distress regarding binge eating which is present after eating. The binge eating must occur on average at least once a week for 3 months, and the binge eating is not associated with recurrent use of inappropriate compensatory behavior and does not occur during the course of bulimia or anorexia nervosa. Rationale for the inclusion of BED is based on the findings of several validators. In terms of antecedent validators, there's evidence from family history studies that binge eating disorder tends to run in families and is not a simple familial variation of obesity. Furthermore, in comparison to other eating disorders, BED shows relatively distinct demographic profiles with a greater likelihood of male cases, older age, and a later age of onset. Studies of concurrent validators shows that BED is also differentiated from obesity in terms of greater concerns about shape and weight, more personality disturbance, and a higher likelihood of psychiatric comorbidity in the form of mood disorders and anxiety disorders. BED is also associated with lower quality of life than is obesity. Finally, in terms of predictive values, BED may be differentiated from other eating disorders in terms of its lower level of diagnostic stability and greater likelihood of remission. Clinical course of BED also shows a greater likelihood of medical comorbidities that is typically not seen in obesity. Finally, in studies and treatment response, there's evidence that individuals with BED have a more positive response to specialty treatments than to generic behavioral weight loss programs. And finally, we'll take a look at the proposed changes to the DSM-V for body dysmorphic disorder. Among the work group's recommendations is the proposal to rename the category somatoform disorders to somatic symptom disorders, because the current terminology for somatoform disorders is confusing, and because somatoform disorders, psychological factors affecting medical conditions, and fictitious disorders all involve presentation of physical symptoms and or a concern about medical illness. The work group suggests renaming this group of disorders somatic symptom disorders for this reason. However, more specifically to body dysmorphic disorder, the work group is recommending that disorder be reclassified from somatoform disorders to anxiety and obsessive compulsive spectrum disorders. A major change. There are several recommended changes proposed for the rewording of the criterion for body dysmorphic disorder. To begin with, in Criterion A, the current reading reads, a preoccupation with an imagined defect in appearance. If a slight physical anomaly is present, the person's concern is markedly excessive. In an attempt to clarify the criteria's meaning and to make it more acceptable to patients, the work group proposes a reading that states preoccupation with a perceived defect or flaw in physical appearance that is not observable or appears slight to others. In Criterion B, it currently reads, the preoccupation causes clinically significant distress or impairment in social, occupational, or other important areas of life. Examples are being added to increase the awareness of some of the common types of distress or impairments in functioning, and the proposed reading would be, the preoccupation causes clinically significant distress. For example, depressed mood, anxiety, shame, or impairment in social, occupational, or other important areas of functioning, for example, school, relationships, and household. In Criterion C, it currently reads, the preoccupation is not better accounted for by another mental disorder, e.g., dissatisfaction with body shape and size and anorexia. The proposed revision would read, the appearance preoccupations are not restricted to symptoms of an eating disorder, i.e. concern with body fat or weight. It is recommended that this criterion be limited to eating disorders, as to the work group's knowledge there have been no other disorders that might easily be confused and misdiagnosed as BDD. Before final recommendations are made, it's important to examine the DSM-V criteria for eating disorders and examples of eating disorder NOS to determine whether Criterion C should or should not be included in eating disorder NOS. There is also the recommendation that there be specifiers for BDD, including muscle dysmorphia, form of body dysmorphic disorder, which is the belief that one's body build is too small or is insufficiently muscular. Specifiers such as this appear to have several important differences from other forms of BDD, such as higher rates of suicidality and substance use disorders, and the treatment approach to these types of specific disorders may require some modification, thus adding this specifier may have some clinical utility. Additionally, there is consideration to specify whether BDD beliefs are currently characterized by a good or fair insight, which recognizes BDD beliefs are definitely or probably not true, or that they may or may not be true. Poor insight, which is where one thinks the BDD beliefs are probably true. And delusional beliefs about appearance, which is that the person is completely convinced that their BDD beliefs are true. There appears to be far more similarities than differences between delusional and non-delusional BDD, and thus it is recommended to combine BDD delusional and non-delusional variants into a single disorder and to eliminate the delusional variant from the psychosis section. The proposal levels of insight are familiar to categories also used widely in scales for BDD. Additionally, an option is to be considered to add BDD-related compulsive behaviors such as mirror checking, excessive grooming, and skin picking as criterion for the diagnosis. Furthermore, an alternative option in Criterion B is to exclude examples of distress and impairment which are not included in other criteria sets, or other disorders could include such examples throughout the DSM-V. Again, the changes mentioned are not the finalized versions of these diagnostic criteria, and your input is welcome, but you only have until April 20th to comment. For more information on these changes and to get information about making comments, you may go to their website at www.dsm5.org. Thank you.